Okay guys, so I'm going to try to continue with the lecture here. We'll see how well it goes. My kids are downstairs roughhousing, so we'll see how long I can keep this up. But we'll start here with gestational hypertension, which I think is where we left off. You'll find this information on page 90 in the book. All right. So gestational hypertension is formerly known as PIH, pregnancy-induced hypertension. It is a hypertensive disease of pregnancy, complicates 12 to 20% of pregnancies. Obviously, the treatment is going to be controlling hypertension, preventing complications to the mom and the fetus, but there is only one cure for gestational hypertension, and that is delivery of the fetus. So sometimes this does require preterm delivery in order to do what's best for the mom and the baby. Medication is not going to cure it. Medication may help, but the only cure is going to be delivery. All right, manifestations of gestational hypertension include preeclampsia, which has renal involvement causing proteinuria, and eclampsia, which has central nervous system involvement leading to seizures, as well as HELLP syndrome, which includes hematologic and hepatic manifestations. Hopefully you guys remember that hepatic means liver. So hepatic, hematologic and hepatic manifestations with HELLP syndrome. Be sure that you know the difference between these three manifestations of gestational hypertension, the difference between them. You know, one, preeclampsia involves the kidneys, eclampsia involves the central nervous system, and HELLP syndrome involves the liver. All right, a woman's condition can change very quickly from the mild form to the severe form of gestational hypertension. And there is a table 5.5 on page 90 that will give you more information. All right, previously called PIH, pregnancy-induced hypertension. It's elevated blood pressure that develops for the first time during pregnancy. So these patients have no elevated blood pressures prior to pregnancy, no complications prior to pregnancy with their blood pressures, and all of a sudden they become pregnant and they develop these complications. All right, so it does not include the presence of protein in the urine. Blood pressure greater than 140/90 starting after the 20th week of pregnancy, and the blood pressure usually returns to normal by the 6th week postpartum. Okay. All right, so be sure you know this stuff about gestational hypertension. Severe gestational hypertension, preeclampsia, the pathophysiology is that they have generalized vasospasms of the arterioles, resulting in poor tissue perfusion, decreased vascular resistance, and elevated blood pressure. Okay, so therefore they get decreased uterine blood flow. All right, increased blood pressure levels causing a decrease in the blood flow to the uterus and placenta. Renal vascular changes resulting in decreased renal blood flow causing proteinuria. Central nervous system changes, which include cell damage leading to cerebral edema, headache, visual disturbances, and irritation of the nerve endings, which is hyperreflexia. And hepatic alterations, including enlargement of the liver and epigastric pain. So if you'll remember, we just talked about the preeclampsia, eclampsia, and HELLP syndrome. One was the kidneys, one was central nervous system, and one was liver. Be sure that you can identify them based on these identifiers here. All right, so we normally have to ask our patients routinely that have PIH, pregnancy-induced hypertension. We're asking, do you have a headache? Are you having any blurry vision? Do you see any spots? Do you have any, seeing spots is called scotoma. Do you have any epigastric pain? And these are questions we routinely ask preeclamptic and eclamptic patients. All right, so a combination of these signs precedes seizures. So the one big difference between preeclampsia and eclampsia is the seizures, because the eclampsia affects the central nervous system, whereas preeclampsia is the kidneys, and HELLP syndrome is the liver. All right, blood and liver. All right, so maternal risks here, listed under preeclampsia. It's hard for me to say that that really should be listed under preeclampsia. Again, these slides had already been pre-done. But as we just discussed, seizures and cerebral edema, seizures can lead to cerebral edema, but seizure, stroke, these are all going to be related to eclampsia versus preeclampsia. Pulmonary edema can come from preeclampsia, acute renal failure, abruptio placentae due to the uteroplacental insufficiency and constriction of the umbilical vessels. And we can actually get maternal death, and that is why this is such an important complication that we need to monitor. All right, severe gestational, we've already discussed this, HELLP syndrome, and DIC, we talked about that Monday, with disseminated intravascular coagulation. Now, back to HELLP syndrome. HELLP syndrome stands for hemolysis, elevated liver enzymes, and low platelets. So again, because we said it was a hepatic and a hematologic, so hemolysis is hematologic, so hemolysis, elevated liver enzymes, and low platelets. That's what that stands for. All right, fetal complications if the mom has preeclampsia. We've got reduced blood flow to the placenta, fetal distress, often can lead to preterm delivery, and IUGR, which is an intrauterine growth retardation. So this a restriction, which means that the baby, if the baby is 36 weeks, we would expect the baby to be, at least a good 5 to 6 pounds. We may deliver this baby with the preeclamptic mom weighing only, 4.5 pounds. That's IUGR. The baby may have ARS, RDS, and other complications related to prematurity. So hopefully you guys remember RDS, but if you don't, that's respiratory distress syndrome. Now you can get more information about HELLP syndrome on page 92 in your book. It occurs in approximately 10% of severe gestational hypertension conditions. Onset of seizures may be sudden. Hematologic abnormalities exist along with this severe form of gestational hypertension, and it is very, very serious. We do get some patients with HELLP syndrome, and they stay in labor hall and or go to ICU, down to the ICU. It's very serious. All right, here's your HELLP syndrome. So hemolysis, you have anemia and jaundice, elevated liver enzymes, so an elevated ALT, AST, epigastric pain. That's why we ask them, do you have any epigastric pain? Nausea, vomiting, and low platelets results in thrombocytopenia, abnormal bleeding, clotting. Bleeding gums will be a very common sign, and they may possibly be in DIC. All right, risk factors. Some studies suggest it may be genetic or an immune response, but so we need to look at family history. Those of African American descent are at higher risk for gestational hypertension. Nulliparity. So if this was the first pregnancy, greater risk. And maternal age. So we've got the extremes. You're either young, younger than 20, or older than 35. Pregnancies with a different partner, and multifetal pregnancy. I don't know if y'all can see that on the page there, but multifetal pregnancy as well. Now, I think I've probably told you guys this story, but I'll tell you again. One of my first instances over in labor hall when I was orienting was a young girl. I think she was only, 14 or 15 years old. And the way that her parents found out that she was pregnant was because they found her in the front yard seizing. So she was eclamptic and was pregnant, obviously, had very elevated blood pressures, and that's how they found out that their child was pregnant. They brought her to the emergency room, and in the emergency room they did testing to determine that she was pregnant. So very much a shocker for that family. All right, documented hypertension, systolic for severe preeclampsia. Your systolic will be greater than 160, diastolic greater than 110 on at least 2 different occasions, 6 hours apart. There have to be some guidelines to say yes, you're preeclamptic or you're not. We also may have proteinuria, so a 3 to 4 plus on a dipstick, or 5 grams or greater on a 24-hour urine collection. All right, clinically, what they're going to present with is non-dependent edema involving the legs, hands, and face, hyperactive deep tendon reflexes. So, when you tap on your knee and your leg jerks, those are going to be super hyperactive. Clonus results from severe preeclampsia with central nervous system involvement, and we'll have blurred vision or double vision as well. Clonus, look that one up if you don't know it. Okay. What else here? Okay. Severe preeclampsia, clinical presentations continued. So we've got elevated liver enzymes, low platelets, severe headache, usually preceding the seizure with cerebral edema. Seizure or coma, this is when you get eclampsia, of course, we talked about. Pulmonary edema from fluid overload. Most of the patients that I've seen with severe preeclampsia have developed pulmonary edema and do have some serious fluid overload, which we usually have to give diuretics for. All right, so clinical or client fetal assessment, screening for antiphospholipid antibodies prior to 34 weeks. If it is detected, there is an increased risk for severe gestational hypertension in the pregnancy or in recurrent pregnancies. Also, close monitoring of the blood pressure and proteinuria. These patients that are kind of on the borderline for do they have preeclampsia, are they eclamptic, preeclamptic, they will be seen sometimes weekly, sometimes bi-weekly in the clinic, getting their blood pressure checked, and they'll tell them to go home and check it at Kroger's or whatever, and they'll tell them if you have any of these signs, which would normally be headache, blurred vision, epigastric pain, seeing spots, they'll tell them they need to call their healthcare provider immediately. We'll also find their platelet counts. Antepartum, we'll do an NST, and do serial ultrasounds to make sure everything is going okay. All right, prenatal home care, we got to make sure there's telephone access, transportation to the hospital at all times. So I think we mentioned this on when we discussed previous. That does not mean you can stay home with your child. There has to be someone there that can take you to the hospital at all times if they let you go home. All right, fetal kick counts, they're going to be on bed rest more than likely, and it's usually preferred to be on the left side to increase the blood flow. All right, decreasing blood pressure and edema as well. There are also home care considerations listed on page 92 in your book. Take a look at those. They're going to be restricted activity, which sometimes is difficult because the mom may not feel bad particularly. Sometimes she does feel pretty bad and she doesn't want to do anything anyway. They'll tell you to keep daily weights, dip your protein for urine. They'll send you home with the protein, with the bottle, and tell you about how to dip your urine for protein to monitor that. They'll do blood pressure monitoring. We talked about reducing stress and sensory stimulation, and having a high protein diet to replace the protein that's lost in the urine. So hospital management for mild to moderate gestational hypertension, the same thing is really bed rest, quiet environment. We're going to do your blood pressure every 4 hours minimum and as needed. So if the patient starts complaining of headache, blurry vision, scotoma, or epigastric pain, we're doing a complete set of vitals to make sure. Daily weights on these patients in particular, protein dipsticks with each void. We're definitely checking it. It's not always with each void, but we're definitely checking in the hospital. And deep tendon reflexes for signs of clonus. So again, be sure you look up clonus if you're not familiar with that. This patient will definitely be on seizure precautions, so we will have to have the side rails padded, oxygen and suctioning at the bedside. We need to monitor diet and fluid intake, fetal kick counts, lab work, worsening condition, and betamethasone will often be given if there is a possibility of premature delivery to help develop the baby's lungs. Now, if we've got severe gestational hypertension, again, we're on bed rest, dark, quiet room, no visitors. We will limit visitors. Seizure precautions, again, decreasing anxiety, monitoring the labs, and we'll do blood pressures every hour. Also doing a urinary output and possibly protein dipstick checks every hour. All right, DTRs, that's deep tendon reflexes, and the clonus checks every hour, assessing for signs and symptoms, assessing fetal well-being. Now, we will often as well give magnesium sulfate. So this is a CNS depressant to prevent seizures. Okay. Oxytocin, may be given for induction of labor or C-section if indicated. So you need to be sure you understand about this magnesium sulfate and why we're giving it to these patients with this. It's not decreasing their blood pressure, I guess is what I'm getting at. So we were giving them mag sulfate We're also giving them other blood pressure medications to decrease their blood pressure because the magnesium sulfate is not decreasing blood pressure at all. What it is doing is trying to prevent the